There he is. All right, guys. So
Hey,
for
guys.
watching, thank you for signing on. What this is, a little overview. This is MedEd Conversations. And where did this come from? Well, where did MedEd come from is we were listening to people, right? Listening to our colleagues, our fellows, our residents that we train, and we're trying to fill a gap that we feel is necessary in education in the medical community. So we have the MedEd Combine where we do the VR events. We're going to have a MedEd certification event coming up, and now we're going to have the MedEd Conversations. And what this is just a short 20, 25 minute, 30-minute conversation about a topic. We're going to be doing once a month, the second Wednesday of every month. Myself, Dr. Chad Stevens, Dr. Rastogi. We're going to have some guest panelists. We already have some things set up for January, just talking about our field and medical education in general. There's a lot going on in our field, and I think sometimes it's really good to get out there and talk about it. Anyone that's listening as a not as a panelist, but on as an attendee, please don't hesitate to raise your hand and ask questions. So that going forward, we'd like to get started with our first MedEd conversation, and this one is going to be about backgrounds and training in the interventional spine field. And where did this come from? Well, the three of us who have talked many, many times realize that we all have many different backgrounds and how we got to the same spot and ended up being, colleagues in the same field. So we're from different areas of the United States. AJ's up in the Northeast, freezing, obviously. Chad's over in Texas, and I'm down in South Florida. We all have different backgrounds in our residencies and our fellowships, and we're all of different age groups, and we've all come together and we all work together very well. So I want to have that conversation about how we started, where we came from, and how we end up where we are. So I'm going to kick it over to you, Chad, and just give a little background of how you got to where you are now.
Yeah. Hey, thanks, Anthony. And thanks, AJ. And anybody who's listening, hope you guys enjoy this. So as Anthony said, we're going to do this every month. So we'll be anxious to hear the feedback we get as always. But so my training started after college. I went to medical school in Des Moines, Iowa, at the university there, and I was able to get my degree as a DO there. So one thing we may talk about today a little bit is I'm a doctor of osteopathy and what that might mean compared to you crazy MD colleagues of mine, and much I teach you guys when you need to know something, all that stuff. But then I went on and did a program in Fort Worth at John Peter Smith Hospital, going through a primary care sports medicine program, and then followed by a pain program. So I did the sports medicine and a pain fellowship. So 2 fellowships, which in theory, that makes me twice as smart, but in theory, it makes me realize how much you don't really know, right? And so that's my start to get into pain. And there's a lot of other backgrounds people can take through the primary care route with internal medicine, emergency medicine, pediatrics, family practice. And so that's very different than you, AJ. What about you?
Yeah, I mean, like we said, interventional spine pain management is so diverse, and I think it's great to see all these different training backgrounds. I grew up in Virginia, so I went to University of Virginia for college and medical school, and then from there went to University of Pennsylvania for an anesthesia residency. I stayed there for a interventional spine and pain management fellowship in the anesthesia department, and that road has led me to private practice. I ran a private practice in Maryland for a while. I opened a interventional spine and pain program at a local hospital, a new department. And from there, I flipped over back to private practice again. So it's been a fun road.
Smart. Great stuff. What about you, Anthony?
Yeah, my background from upstate New York, med school in Syracuse, PM&R residency, which we all know is the best residency to go into interventional spine and sports. Then I trained under Dr. Brad Goodman down in Alabama with a bunch of other PM&R residents. So that's the first thing I want to get into is the difference in residency and fellowships. Chad, you're sports trained, AJ, you're anesthesia trained, and I'm PM&R trained. And we get into little fights about this all the time. And I think they're playful fights that I think AJ can't do anything but calculate milliequivalents of morphine. And Chad can't do anything outside of the shoulder and the hips. And I think PM&R does it all. We do the nerves, we do the muscles, we do hundreds of EMGs because we have to. That's still a recommendation in our field. And we do a great physical exam. But what I've learned from Chad, he thinks he does a great physical exam as well. What I've learned is that I can learn from you guys as well. So in my mind, my little stick for PM&R, which I know a lot of people that are watching are probably PM&R background, is that keep that physical exam with you. You might hate doing your 20-minute long physical exam in residency, but it'll take you miles when you get to this field and this fellowship. This fellowship isn't just about injections. It isn't just about procedures. Anyone can do the injections. Anyone can do the procedures. Even an anesthesia trained guy can do that. What you need to be able to do is be able to diagnose the patient properly. So that's what my little stick for PM&R and why I think we do a really good job of diagnosing and doing a great job of figuring out where the pain is. Then we have great hands too. So we do great procedures as well.
50, one out of two is not bad. The hands part, debatable.
I've talked to Brittany and she says that your hands are not that great, but that's, I'm just kidding. So
it's going there now.
We're going there, right? So one thing I would add to what Anthony's saying, and I agree that one piece of paper that I memorized before every board exam that shows me all the different places where nerves can get entrapped can serve you well, just kind of like calculus is serving me well. And so
useful.
No, in theory, that does help a lot. But what I wanted to kind of point out is it's very important if you're a pain doctor to be able to differentiate when somebody comes with neck, shoulder, arm, and hand pain, where is that coming from? And, I have colleagues of all different specialties, good, bad, and otherwise, who will send me a cervical radiculopathy. And then I go to examine them and they have a full on open door test. And they also have an arm drop test and they have extra rotation weakness. So they have a full on rotator cuff tear. And that's why they're getting radiating pain in their deltoid. It's not because of their cervical radic, or they have carpal tunnel syndrome and the pain is radiating up into their shoulder. And so I think it's important to be able to differentiate anything throughout the extremities. And so that's one of the reasons I like the sports medicine training. But I think that there's a lot of overlap in a lot of our programs, because you can't be a pain doctor and not get some patients that are referred to you that really belong somewhere else. But you can really become an asset to a practice and a community if you can differentiate where the pain is being generated. A lot of times we're able to go and do the treatment ourselves. That's part of the interventional pain training we all have, where it's not just writing prescriptions. It's, in fact, Anthony writes no prescriptions and I write very few, and you too, AJ. But it tells you that not only can you treat it sometimes, but if not, you can say the C6 on the right is where that pain's coming from. Operate there and everything will be great. And so I think that physical examination history is kind of lost in a lot of today's medical students. So I want to really encourage you, if you're listening and you're a fellow or a medical student, don't forget the physical exam. If you listen to your patients long enough, they'll tell you what's wrong.
Too true. I think pain management wouldn't be where it is without anesthesia. It was created by a group of anesthesiologists, and most of the fellowship trained programs are on a foundation of an anesthesia platform or anesthesia training program. But my fellowship experience, which was years ago, was a experience that was multi-specialty. So you rotated with PM&R, you rotated with neurology, psychiatry, orthopedic and neurosurgery, physical therapy, and anesthesia. So for us, that was a much more robust experience than I think if you didn't get that type of environment. And I think that's where a better training experience is going to be for all of us. We're all going to learn from each other. I think for anesthesia, what I thought was fundamental was the physiology and the pharmacology that we get in terms of that background. I mean, I think we really understand drug development and drug utilization from a pharmacokinetics and pharmacodynamic standpoint. And that is helpful when you want to build a comprehensive pain management program. I think in the interventional piece, we do a lot of interventions. We do a lot of labor epidurals without, radiologic guidance. So you get quite good in anesthesia programs to do that. And I think you build upon that in your fellowship year. So, when these guys need help for their procedures, they call me. It's okay. I don't talk about it. I don't talk about it.
But here's the problem with what you just said, AJ, is you decided what you want to be when you grew up. You said, I want nothing to do with awake patients, right? I want them when they're asleep. I want to keep them asleep. pick up, I'm leaving and going to dinner, right? I don't want to take call, right? Because that might be the surgeon's job. But so
all
one
the
of the things I
residents
want
in
to harp
anesthesia,
on,
when they
and
find out you want to do pain, all the residents in anesthesia who don't want to do pain, they're like, why would you want to do pain management? This is the perfect job.
yeah,
You don't talk to your patient, you
yeah,
go home, you don't have to worry about anything. Why would you want to do that?
yep,
And it's a real calling. It is what
right,
we do as a calling.
Well, I think that's interesting. One thing we're touching on is how different that you just touched on, AJ, is how different really we ended up from where we started in our residencies and in our fellowships even. You know, I'll never forget, and this happens with every PM&R guy out there, I guarantee it. You know, a lot of the PM&R program directors are hardcore rehab guys, like tried and true spinal cord injury, traumatic brain injury. And at some point in your third year of PM&R, it's a 4-year program, at least where I went, it was 4 years. You make that decision and you let down that program director by telling them you want to go into pain. And the vibe changes between the program director and yourself. And I know there's plenty of guys that went through my PM&R program and plenty of guys I did fellowship with that all tell the same story. And it's just such a difference. And that's going to take me to my last point I want to make. But the next point I want to make is talking really about picking that fellowship. I get this question all the time on Instagram, on LinkedIn, ACGME versus non-ACGME. And this is the statement I make, and I want to hear what you guys say when someone asks you. And it's pretty quick because I don't want to type forever to 100 people on Instagram. So my pretty quick answer is always, listen, if you want to do a good job at diagnosing and a good job of procedures, you need volume. And our fellowship is only 1 year. And where are you going to get that volume is in a private practice. And I actually got in 2 of my job interviews when I was looking after fellowship, they had to call my program director, Brad Goodman, and they thought I was lying about the number of procedures we did, just because of how large our volume was. And I felt comfortable, and I think Brad might be listening. He might say opposite. I felt comfortable seeing patients and doing procedures after 6 months. Felt comfortable, like I knew what I was doing. And I don't think you get that in an ACGME fellowship. I think there's a lot of hoops you have to jump through. I think it is more academic though. So the other caveat I say is I'm in private practice, I'm in South Florida. So non-ACGME served me very well. Now, if I wanted to go to NYU or Johns Hopkins and be a program director or, you know, head of one of those fellowships, I think you would have to do an ACGME. I don't think they would look at our application. I'd like to hear what you guys think about that, ACGME versus non-ACGME.
So for us, our program was in Fort Worth, but it was through Dallas Southwestern Medical School. So it was a ACGME accredited program. And initially we actually took our pain boards in PM&R. So we're more like each other than you want to admit, Anthony. So I think your valid point. So I'm going to one up you just a little bit. There's a guy named Brian Longcar who is an attorney in our community who advertises and has all these little cute commercials with ex-Cowboy players and all these people. And I'm not saying he's an ambulance chaser, but so when I was a fellow, I decided that our fellows needed to be adept at doing kyphoplasty. And I had the inside knowledge that the ER doctors at our hospital tended to put people in a brace and send them home. So I went to the EMR and scrubbed all the patients that I had seen over the last 6 months from my, you know, from when I was a medical student to when I was all through my program that were my patients and had been to our ER and turned away. And I called them all back and said, are you still hurting from your compression fracture? And they said, yes. And so called them in, did kyphoplasty. So I agree that you have to really churn and burn to get as many numbers as you can. I think that really helps you when you're applying for privileges. Obviously, I mean, I'm applying to 3 new places for privileges in the next month. Every one of them wants my case logs. And then when they see how many years I've worked at other places, they're kind of like, okay, forget about the case logs. You know, it's like, you just really want to have numbers behind you with good results, because we all know that you can do a few procedures well and not run any trouble. When you run into trouble is when you do multiples and multiples and multiples of procedures. And you want a guy like Brad Goodman looking over your shoulder going, what you got going on there, Anthony? Oh, no problem. I'm just holding pressure. The bleeding should stop eventually. I read that in a book somewhere, because that's what you want to make your mistakes and learn your lessons when you have an attending over your shoulder who has all kinds of experience.
No, too true. You know, and I've trained a lot of fellows, as you guys have. We've hired a lot of fellows, and the variability from program to program that was ACGME accredited is huge. You could go to one program and maybe do 3 or 4 STEM trials a whole year.
Yeah.
And you could go to another program and you've got more than you know what to do with. And so I think someone who's going from a primary residency of anesthesia, PM&R, neurology, and going into a fellowship year needs to know what that volume is going to be before they get there so they can make the right decision. And like you guys said, if you're not focused on being on the academic track, if you're focused on joining a private practice, then you really have to have the volume, because you don't have as much support. In an academic program, you might have residents, you might have fellows, you might have other attendings to call on. You might not have that. And so you want to be really secure. You want to be really confident when you go out to the community, because you might be the only one doing this.
Yeah.
And you want to have seen everything and be comfortable that way.
Yeah. And
it's a great point, AJ, is the seen everything.
Yeah, we've kind of gotten to the point where we say some edgy stuff. So let's say something edgy here. Let's say you
edgy time. This is edgy time.
Edgy
banner.
If
Warning.
would be a great pain fellowship. In my mind, it would be a bunch of the little procedures, but exposure to these other things that are really, in my opinion, separating us into spine, interventional spine proceduralists, right? Not spine surgery. That's not our goal, but doing interventional procedures. So if I were a fellow, I would say I need to see a bunch. I mean, you got to do a bunch of epidurals before you can do a cervical epidural, and you got a bunch of RFAs in the lumbar spine before you do a cervical RFI. But you also want to say, hey, show me your SI fusion, show me your lumbar fusion, show me your and some of the fellowship directors might disagree, but I think that's really important that pain doctors that are coming out of programs, the doctors that are watching now with all the exposure we have from spine surgeons and neurosurgeons, they're going to start expecting the fellows that come out to not just be injection jockeys. And so I think it's important that we get exposure to these more complicated procedures.
No, I think that's a point I'm going to
absolutely true
in a few minutes as well. Dr. Goodman is watching and chimed in and said the program at one time was ACGME accredited, I guess before my time, and changed the requirements, which made it no sense to continue. And I've heard that elsewhere, that just the requirements for ACGME just don't make sense really for our fellowship, which is really all building up to one of these last points I want to make. One point I want to make before we get to our last point, and we are going to try to keep this to 25 minutes because I know people's attention span, but I think this is really good. We're trying to have is internal fighting in our field between all these different specialties. I think sometimes we see it as a turf war, and I've talked to some other docs separately at meetings, and I want to get this out in the open that I really think any internal fighting in our field is just poor for our field, and it looks bad. Like I said, I work with 14 orthopedic surgeons. I'm the only interventionalist. And the statement they always say to me, and they say this is a compliment, and this is the orthopedic surgeons, and you've probably all heard this. They say, Anthony, somehow we hired the only non-morally bankrupt pain doctor. And I'm like, that's an insult. I'm like, I know you're trying to compliment me, but that's an insult. But why does it look that way is because of all the infighting that we have. And even on social media, on LinkedIn, sometimes we have a little too much infighting that we think one is better than the other when we're really all should be pulling in the same direction. We joke anesthesia is good at giving meds. I joke sports medicine is good at doing like football and sideline coverage, and PM&R is the best. But we all need to work towards those same goals and work well together.
And all three of us have pain fellowships, and during our pain fellowships, we developed our own skill, and everybody has their own art to how they practice, right? Some people are 3 shots, 3 sets, and then, they go through these algorithms. And so you develop your own speed of how you do things. But I would say, I would agree with you, Anthony. The reason I know you're right, and I don't ever say that for those of you who are on this call, almost every call arguing with Anthony, but
once a year,
when it comes up on LinkedIn, it's not you guys that call me and say, hey, check this out, we need to do something. But I've literally been on vacation, and reps and or other spine surgeons have texted me and said, dude, what's going on with you pain doctors on the line? Why are you guys arguing about this? Find a better forum than this other, And so I think social media has become part of all our lives through our our COVID times, and it's a necessity for all that we do. And I think it's critical. And all three of us use Moxie, and we can't say enough about Moxie. But that said, I don't think social media is meant to be our platform for necessarily arguing, disagreeing, and or degrading one another. And I'm still kind of trying to figure out where that platform is going to be. And we've looked into some other platforms, but I'm the first person to believe that iron sharpens iron, and we can be constructively criticizing each other, but we need to be all on the same team, especially when it comes to trying to get across to some sort of an entity that pain doctors should be qualified and able to do this. Well, if somebody comes and looks to see if we're doing something and they say, well, even among yourselves, you don't get along and you can't decide among yourselves. So why should we as another entity decide that? I think it only hurts us. And so I do want to encourage everybody that's on the call, whatever track you take, find your way back to and some of the societies are very specific for anesthesia. Some are for interventional radiology. Try to find true north for you, whatever society that is, where you feel the most comfortable, but don't surround yourself with people exactly like you, exactly trained like you, exactly your personality, exactly
Right.
your skill. Find people that are going to make you better. I look for people that are going to push me and make me do things I might not feel comfortable with at first, but that's how you grow.
I mean, you should be a lifelong learner. I agree with Chad and Anthony 100%. And you want to be in a place where you're a little uncomfortable. That's where you're going to learn the most. You don't want to surround yourself with the same specialty, the same thinkers. You're going to get very pigeonholed. And so have a diverse mix of mentors. One of the things that we find you probably don't get a lot of in any fellowship is simple things like radiologics. You're probably not reading enough films. You may not even know how to read a film when you get out of fellowship. And we highly encourage that first, second year out of fellowship is almost like another fellowship year, where you're going to courses to learn MRIs and CT scans. You're going to courses to learn physical exam. So, you can go to the PM&R course and, you can get everything you need to know in PM&R in like about 2 days. It doesn't take long. And then, you add that to your repertoire. So you become a more well-rounded clinician.
You need PM&R training. Did I hear you say that?
It's about 2 days. It's
Okay.
not long. I think it's like, I did it online. It was like Stryer DeVry Institute.
It was like Phoenix.com or something like that.
Lincoln Tech, something like that.
So that brings me to our last point, and it's something that I've said for a while. And in my mind, the fellowship is where we need to hone all these people in and really have some kind of continuity on what we're doing. We can't have one fellowship where people come out and have done 3 cervical epidurals all year, and another fellowship where people are doing SI joint fusion, stim, kyphoplasty, and very proficient. For the fellowship, this is the joke we get from orthopedic surgeons, is like they come out of fellowship and they are ready to roll, right? They are ready to go. They get killed in their fellowship. They get killed in their residency. They don't need more training. They're ready to go. We come out and everyone has to go get trained in all these procedures now, which blows my mind. We're actually, we're trying to set up an event for fellows so that they can get trained in all these procedures before they finish, which will be in February. But do we have to look at our fellowship and change it from pain management to interventional spine and sports? To me, those are 2 different fellowships, and it's just a difference of the times. Pain management is in the world of pain is the 5th vital score, Purdue Pharmaceutical, oxycodone, crazy parties. You've all seen the Netflix series. AJ got to take a part of those. I did not, because he was in anesthesia. But do we need to have an interventional sports and spine fellowship where the requirements are when you come out, you have to be proficient in cervical, lumbar, thoracic, and then also proficient in SI joint fusion, lumbar fusion, lateral lumbar fusion or posterior lumbar fusion, kyphoplasty. I just think there's too much ambiguity between all the fellowships. And how do we do this? Is this just a pipe dream? Are we able to do it? Is it just the fellowships aren't keeping up with the new technology? What do you guys think?
I think depending on the fellowship you go to, how open-minded they are to new interventions, and how much control do they have over their own destiny versus having to take that to the orthopedic or the neurosurgical department and making sure they're not potentially stepping on their toes, right? There have been some fellowship programs where the fellows came out and they said, I haven't been able to do those because we have to go through orthopedics or neurosurgery as a backup. We have to have them as a backup in the room when we do these cases. And for them, that's their repertoire. That's how they work. But that's not how the community thinks. That's not how private practice works. And so it's just not feasible to have someone in the room with you for all of these cases. It's just overkill, right?
Yeah.
So I think you're 100% right that as a society, we have too many variabilities between individual practitioners. You could have someone who just does medication management, right? And that's all they do, and they're called a pain specialist. And then you could have, like, say that PM&R doc does EMGs and trigger points, and they're a pain specialist. And then, was that your fellowship? No, I'm just kidding. And then, and so I agree with you. A real comprehensive fellowship program should make you confident that you can handle all the conservative pain measures. You can handle all the workup, the exam, all the diagnoses, and all the different bread and butter plus advanced interventions that are out there. Then you're a true comprehensive specialist, right? You can tackle anything that comes through your door. And that, I think, is what all three of us are striving to build and try to raise the awareness. I mean, when I go to a referral provider, I say, look, I don't know what you know about pain management, but please don't think of the P in pain management as Percocet. That's not what we're trying to do here. And it's a tough battle to fight out there.
No, it is. And so the way I would answer that, and I'm going to take a little different slant. I agree with everything that was said, but I'm also going to say, if you're a program director listening to our call, the intent is not to slander or slam you, because we've all been there. We've all had fellows, and I know this because every class has Dr. X. And Dr. X is the person that you're afraid to be in the room, stick a needle anywhere in anybody because they're dangerous at first, so they're not talented enough for that. And so I get it, but could there be a way to say, okay, these 4 out of these 6 doctors really have an interest and a skill set capable of taking them to these other procedures? Could you, within your own fellowship, maybe even differentiate that? I mean, I'm not at all advocating like a stair step program like they have in general surgery, where like start with 6, end with 5, and then go down to 4, and then 3 make it. That's not what I'm talking about. But maybe if we could assess the level of interest, and the doctors that are the attendings could say, this person here, I think, has the interest in working private practice and has the skill set. Let's take them a little different track. Maybe that would be an initial thing. Another thought would be, what happens after a while, after you start subspecializing, is you have to make additional training. So what if there was an additional year of just advanced pain? And so people get their basics, get really good at interpretation, like you have alluded to. Thank you for talking about reading your own MRIs, AJ, and learning how to interpret what they're seeing on fluoroscopy, how the hands work and what does with needles and with knives. And then they get, to the point where they're like, I think I want more. And instead of having to go to all the meetings, maybe they just have another additional fellowship in advanced pain.
That's awesome, guys.
It's a cool idea.
Our Mark, and I think that's really where we need to advance our field, is in getting the fellowship aligned, getting them all aligned. And I don't hate that 1 or 2 year fellowship. The 1 year is the same for everyone. And then the second year is if you want to do that advancement. I know a lot of residents and med students out there are like saying, yeah, we don't want to do another year without getting paid. But I think it will behoove them to do that in the future. So
Moonlight.
What's that?
Moonlight. Moonlight.
There you go. But this has been awesome. I mean, this is what this is all about. Fun. We're trying to take a topic and really dive into it. And this will be recorded, of course. We'll put it on our social media. We'll put it on our LinkedIn. It'll be out there. Thanks, guys, for signing on.
Can I take it real quick? Can I take us home?
Yeah, take it.
I want to bring this back to why we're all doing this. When you were a baby doctor and you were applying for medical school, do you remember what you said? You didn't say, I want to be the best kyphoplastiest. You said, I want to serve people. I want to help people. I want to do the very best thing I can for my community and my family and my friends to help them live good, functional lives. And that's what it all comes down to. The reason we're trying to better ourselves and the reason we're trying to learn more procedures is there's a subset of people that are kind of ostracized from big surgeries and put on pills like AJ talked about Percocet and things. And so take it all back home. This is about being the best you can be for your practice, to help your partners out, to become the most capable in your practice of what you can do. But it's all about patient care, making the right decisions based on patient presentations, and having the skill set to fix the problems as best you can and to give them the most functional quality of living you can.
Well said.
Very well
said,
said.
Chad.
I think we end it there. We will have another conversation in January. The second Wednesday, we'll be doing these at 8 o'clock Eastern. We will be having some guest panelists on that one as well, talking about the ever-changing world of insurance approvals and how to go through that. So that'll be really good to look at, not just insurance approvals, but also how we go about collecting data through our EHRs and through all that. So thank you guys. For anyone out there, thank you very much for joining in, and catch us next time.
Thank you, guys.
Thanks, everybody. See you soon.